So good afternoon. I'm Kate Veach, for those who might not know me. I have the honour of being your Assistant Secretary here at the QNMU, and I am a wishful person who would have loved to have become a midwife, but I am just a registered nurse. So I take my hats off to you all. So today we're going to get started with a acknowledgement of country. And so on behalf of all of us, we acknowledge the traditional custodians of this beautiful land, waterways and air in which we meet today. Here in Kurilpa, which is West End, in Meanjin, which is Brisbane, I'm meeting on the country of the Yagara and Turrbal people, and I pay my deep respects, and I hope you can extend into your areas as well, to the traditional owners of the lands where you are meeting, and also pass on my respects to any First Nation people who are joining us today. This year, we have the opportunity to make history in changing the Constitution of Australia to rightfully recognise First Nations people and to provide a constitutionally enshrined voice for Aboriginal and Torres Strait Islander people to Parliament. This is a very easy and simple referendum that is before us, and it is simply about answering a question about making sure Aboriginal and Torres Strait Islander people have that voice. People will try to confuse you and do a whole range of things, but it is as simple as that. So we're hoping that you will join the QNMU as a part of the Queensland Union Group in supporting a campaign for yes. And we know that this campaign is a campaign that will be won in the field, which means it will be won at your kitchen table having discussions, or in your work areas, or in your community. So if you need more information, we have it on our website. We have links to lots of valuable information. So just join in. If you've got any questions about that, you can slip them over to Colleen and we can get in contact with you. So all of our meetings at the QNMU, whether they're online or in person, we like to read a statement of safety and respect. And basically, the statement of safety and respect is about making sure that we all feel valued in the meetings that we attend. We feel safe when we're having them, and that we feel respected in having them as well. So the QNMU is committed to ensuring all of our gatherings and functions are free from all forms of harassment, discrimination, and racism. So all attendees have the right to feel safe and respected. If you've got any problems with the meeting today, please let Belinda or Colleen or I know. So in terms of getting started today, we're here to talk about Count the Babies. Now, obviously, you are all probably very much across where we've got problems. The problems sit in some very old legislation, and they also sit in our funding model. Midwives are not opposed to fighting for funding changes. You've been doing it for a very, very long time. But this one is sort of a little bit more complicated because we've got a federal view and we've got a state view. And both of those governments have the ability to do things differently right now. And at the moment, they're kind of in a crossfire with each other saying, no, if you do that, then we'll do this. So what we need to do is keep the pressure up on the campaign. Our foot's got to remain on the pedal. And as we know, we don't win things overnight. The union movement is about struggle. And this is a process where we need all of our members at the QNMU, nurses, midwives, AINs, to get involved in this campaign and to provide some shoulder to the wheel to make sure we keep the pressure on decision makers to do the best thing that they can, which is obviously changing a very old piece of legislation that's older than me. And I know I look young, but I'm not. So we need to be able to change that. And then we need to be able to make the necessary changes in our funding model to make it fairer. So midwives are safer in terms of their practice, but also that they can provide the right care to women and people who give birth, and their families and their communities. So I'm going to hand over to Belinda, and it's lovely to see more of you on board. So if I haven't personally said hello to you all, you're getting a personal hello now. For those who have joined since we've started, if you feel like you can put your cameras on, we're a small and friendly group. See if you can do that. And Belinda's going to go and get started now. And don't forget, down in the chat function, if you want to tell us what country you're on and pop your questions in there as you're going. Belinda and the team are here to be able to answer those questions as they're going along. Over to you, Belinda.
Thank you, Kate, for that. Appreciate that. I will just share my screen. So I'm doing the presentation, but at any time, if you want to ask questions, just pop them in the chat, and Colleen will say, Belinda, there's a question, because once I put up the PowerPoint, that's all I can see, which is was a bit disconcerting because I'm just looking at the PowerPoint and talking, but that's what we do. That's not it. Now, can you all see that? Oh, good. So, counting the babies, very exciting. I know we've been working in this space for a while, and we're certainly ramping up the pressure, as Kate was saying. So I would like to, can you see that changed, that slide just changed? Good. Now I know. So today I acknowledge the traditional custodians of the land in which we walk, work and live, and elders past, present and future. I extend that respect to Aboriginal and Torres Strait Islander peoples here today, in particular the women, aunties and grannies who hold the wisdom, strength and power of age-old tradition and culture that is women's business. And finally, to all the women, persons and midwives on the many lands with traditional custodians, we at the QNMU hear you, we see you, and we're committed to improving your maternity care provision and experience. So I'm just going to talk around some of the background to why we've come to count the babies and the audit, and so where we've been coming from and where we're heading. So for those of you that might not know, did you know that newborn babies are not counted in the workloads of midwives? And these are some pictures of our wonderful members that did a Count the Babies audit last year. So when a midwife is allocated patients, women, whoever, to care for, we're talking specifically here on postnatal inpatient. So there's lots and lots of things we're doing, the QNMU in the midwifery space, and we know that we need to do a lot of work around the beginning, so accessing more midwifery continuity of care, and decreasing interventions so that women aren't having the traumatic birth experiences they're having now. But this is specifically around the postnatal inpatient care. So when midwives are allocated 4, 5, 6, 7, 8, 9, 10 women, they're actually have another little human attached to them that does require a significant amount of care. Even when they're well and healthy, there's certain things that they need, and so they are not counted in the midwife's load. So if I was to say I'm looking after 5 women today, I'm actually looking after 10 people today, and that's very, very high workload. So all babies are admitted. So when they're born, they're all admitted, but not as patients. And I say patients, knowing midwives will squirm at us using patients for our mothers, persons and babies. But in terms of how they're situated and counted in the hospital, it's patients. So qualified, so all babies are admitted, but they are then considered unqualified. The only way that they become qualified is if they then become a patient. And so then they might have funding attached to them. So we don't want our babies to be patients, but we do want them to, and we want them to stay with their mums and their parents. That's very important. And midwives are very passionate about that. And we're doing that very, very well, to the point where, some babies that probably should be in the nursery staying with their mothers or parents, but we want them to be counted in the workload. So the midwives have the time to provide the care, the education, the support to the mother, parent and baby families. So the outdated funding model from 1973 counts mothers and babies as one. So 1 + 1 = 1 is basically the way the model has been, the model of funding. And that's why at the moment, the Commonwealth is trying to put it on the state's trying to put it on the Commonwealth, because the Commonwealth is saying, well, we're kind of funding them, but they're really kind of not. It's not efficient. And it certainly doesn't factor in the provision of extra midwifery care for those babies, because they're not counted in the workloads. So we're saying the mum, the person, the baby is one unit for sure, but they're 2 people, and they need to be counted as such. So some of the background, we've done surveys in 2016 and again 2019. We did check-in surveys of our midwifery workforce, and we found that there's a considerable amount of member distress out there, and the postnatal inpatient workloads seem to be the ones that are one of the really burdensome ones at the moment for midwives. We're having an escalation of intervention, so more than 1 in 3 women are having a caesarean section, and nearly half of women are induced, and that is not looking at the moment like it's decreasing at any very soon. Our perinatal mortality morbidity outcomes have not improved in over 20 years, but we have actually, we're seeing much more trauma and distress amongst women. And there was a recent published report where they studied over 8,000 women and found 3 key categories that women are saying for birth is: I felt dehumanized, I felt violated, I felt powerless. So this is pretty sad. And so when we're providing care to women in the postnatal period, we're dealing with a lot of women that are feeling this level of distress and trauma around their birth experience. So it's really important, once again, for the mother, parent, and baby to have that midwife time to care. Women, people, and their babies, as I've just I'm getting ahead of myself with talking on my slides. So they need to be enabled to have the time to care. And the problem with midwifery, well, it's not the problem, because midwifery, we know, is very, very strong evidence behind better outcomes with midwifery continuity of carer. We just went to the BIOC 10-year model this morning, and that's just had a recent publication showing that they're in the BIOC model, our First Nations babies, preterm birth is now around 7%, whereas the average, including white babies, is 8%. So they're actually doing better than the state average, the Australian average. So that's around having a continuity of midwifery carer. So we need that's what they need. So our check-in survey showed quite distressing levels of burnout, dissatisfaction, and wanting to leave the profession. So we had in 2016 about 24% of midwives saying they wanted to leave within the next 2 to 5 years. And then again in 2019, we repeated the survey, and we found that number had gone up to 26% of midwives wanting to leave in the next 2 to 5 years, which is quite worrying. Some of the problem that midwives are telling us is they're being forced to work and practice with the models of care that contradict the midwifery framework or the philosophy of midwifery care, which is that time to sit with women and be with women, which is what midwife means, is with woman. So again, that time and around the funding is what we do, or what we don't do is what we do very well. So we don't intervene. We support women with through birth, labour, birth, antenatal, postnatal, but a lot of, because our funding is around activity, so activity-based funding, we often don't capture the financial benefit, although there has been some studies done recently around midwifery care. So in 2016, through engagement and workshops across our midwifery membership, we developed the Safe Workloads in Midwifery Standards. And then again in 2021, we worked with our membership again and did addition 2 of our Safe Workloads in Midwifery Standards, where we were asked to do 2 more standards within that. So this is just a nice little pictorial of what we're talking about when we talk the ratios, which is in the SWIM standard, standard 3. And so our ratios for postnatal inpatient care is 1 to 4 to 1 to 6. So what we want is for everyone to talk, including the babies. So 1 to 4 is 2 mothers, 2 babies. 1 to 6 is 3 mothers, 3 babies. And we feel really strongly that this is really important for midwives to be able to spend the appropriate time in that short amount of time women get in the postnatal period to set them up for health and well-being and confidence and all of those things that are really, really important to the beginning of this new family unit. So I won't read out all of these, but the two new midwifery standards, safe workload standards, are care of women experiencing fetal death or abortion. And then the last one is midwifery leadership must be recognised at all levels. And that's what we've been saying, is midwives need contemporary midwifery leadership with authority, so that we can continue our pathway to grow. So the qualified babies, I have explained that. I won't read all that again. So the majority of babies are considered, if they're well, they're considered unqualified. But we do know that there is considerable number of clinical practice guidelines associated with the baby. So for a normal newborn baby, there's 11 guidelines that can impact on that baby. So around different observations that they need, screening tests that they need. There's quite a range of different things. So other key issues around is that our IT systems don't count the workload of babies, so they're not counted in our systems. We know that we're keeping babies and mothers together, which is really important for us, but that means that the babies that are requiring more care, so staying with their mothers if they need IV antibiotics, a range of different things. They're staying with their mothers, which is great, but it's just, it's still not counted in the midwife's workload. So the midwife will still be allocated 4 or 5 women, and that will be considered a notional ratio, but she might have 2 or 3 other people that need things like IV antibiotics and hourly observations and blood sugar levels and a range of different things. And so it's really quite astounding that they're not counted as a workload. Mothers and babies matter. So we know that through very strong research and publications that nurse to patient ratios are an economically sound methodology, and that they save lives and improve patient outcomes. We know that. That's Queenslanders through the QNMU and the nursing ratios has done some really solid research to show this. So this is really important. So the objectives of the Count the Baby campaign is, like Kate said, we've got our state objectives and we've got our Commonwealth objectives. So we want the state to commit to, our government to commit to implementing ratios by 2025, 2026. We do need to give them a few years because we know we've got workforce issues. So we can't hand on heart say that if we got this implemented now, that we would be able to have the appropriate workforce to be able to be employed into those models. So we'll give them time to build up that workforce and implement the safe workloads and midwifery standard ratios. And then we also need the funding model to be changed. So that funding model, which is more incentivises intervention through activity, needs to be changed. And we need babies to be included in all workload design, allocation, skill mix and ratios. So what have our midwife members been doing over the last year or so? They've been doing lots and lots of workload forms. So we have given a midwives a little card, and so for if there's any midwives online, we are getting a lot more. So you just need to tap into your organizer and get some more of them. And on one side, it just gives some little instructions on how to write up workloads for babies. So babies that have say IV antibiotics or extensive observations because the mother's on certain medications, those sort of things. So we've got that. And then on the other side, we're articulating how midwives can write for coding. And so coding is the way in which coders obviously capture activity that are then funded. And so key to this is, for example, if you say a low blood sugar, so given glucogel as per guideline, that's not codable. But if we give it a diagnosis, it is. So if we say glucogel given due to hypoglycemia is codable. So we've got that information there too. So, and others are attachment difficulties due to flat nipples. So it wouldn't be enough to say I've spent two hours helping this woman breastfeed is not codable. But if you give it a diagnosis, flat nipples or cracked nipples or whatever, then that's codable. And we've counted the babies. So last year, Just be playing with my thing. So last year, we did a snapshot of how many babies our midwives are handing over at the end of their shift. So it's just a snapshot. It's a 24-hour period. So in this 24-hour period, at the end of the night shift, at the end of the early shift, and at the end of the late shift, we've asked midwives, and it's not just our member midwives, it's for any midwife who's working on that shift. So we're asking our members to put up posters, and then they have a QR code and they click on that and it puts them straight into a very simple survey. And so they say at handover, I handed over this many babies and this many women, and this was some of the acuity issues.
Belinda, can
Yes.
we have a question from
Yep.
Tracy, I think it is, saying, can we have a list of these codable terms, sorry?
Yes, absolutely. We'll give out, it's on the little cards that we've got that we give out. So we'll get some more of them and hand them out to everyone. And yeah, no, I'll do that. I'm giving myself more work. I was thinking, I could do a webinar on it, but no, I don't think I've have the time at the moment. But no, I would easily get that out to you. That's not a problem. We had very good response to our audit. We counted in 24-hour period 1,525 babies. We had 444 midwives respond, and we did have quite a cross section of the hospitals that responded as well. Private and public hospitals. The Mater on the day were, so Mater is one of our biggest hospitals, and they just happened to have on that day the quietest day they've had in like 20 years, they said. And they were spewing about that because, yeah, they had like 8 empty beds, which is just unheard of. So I think that they're very happy that we're going to repeat the audit. So of the babies, the majority, of course, were considered unqualified. But all of those babies had some sort of acuity attached to them in that, even if it was just the observations that they needed. So 69% of midwives handed over up to 4 babies. So that's fine. Well, it's fine. That means that they had 8 people they were caring for. A whopping 27%, sorry, of midwives handed over between 5 and 8 babies. So that's 10 to 18 people that they were caring for on their shift, which is when you consider that at least a third of them will be post-surgery, post-major surgery. This is very, very concerning, and even more concerning is the 7% of midwives who had more than 9 babies at the end of their shift. So these are postnatal inpatient midwives. So they're not in the nursery, they are on the ward, and they are caring for 18 or more people on one shift, and that is really concerning. And when I looked at the data, that wasn't midwives on a night duty. And it's a furphy, not having more midwives on night duty because babies sleep, because we know that that does not happen. So we do have less staff and more women persons babies allocated overnight, and it still always surprises me because we know that the babies don't follow that. But so and when I looked at the data, it wasn't on the night shift. Some of the midwives, it was from the night shift, but the majority were on an early shift that had 9 or more babies. So that is a crazy workload, very, very unsafe, and that wasn't factoring in the midwives that they're also overseeing registered nurses or enrolled nurses or students. So they might have been. So if a midwife's looking after, so we had one hospital where the midwife had there was 30 women on the postnatal ward, which means there were 60 people. She had an RN and an EN with her to provide the care overnight for these women and babies. So that means that midwife was responsible for 60 people on a night duty, because the registered nurse and the enrolled nurse are working under supervision. So these are really worrying statistics. We counted nearly 2,000 women. We had it was a 53% cesarean section in that period. And only 29% had an unassisted birth. So that's only 1 in 3 women that are able to, really be fairly independent after they've given birth. And that is, again, that just shows the significant workloads that midwives are carrying. And we had midwives just talk about a few different things. We did see quite a number of babies under 37 weeks counted as well, which is very worrying because babies under 37 weeks are still prem babies. Some do very, very well, but babies can come out and be I'm talking to the non-midwives. The babies that when they're born before 37 weeks can be really pink and chirpy and happy and breathing properly and everything's great. But because of their prematurity, they start running out of steam. And so you might find 24, 48 hours later, that's when they start to crash. So they need really close observation, these babies. And there was quite a number of babies that were under 37 weeks, and the majority were in private hospitals. So that's a worry. So after that, we wrote to, we've written to health ministers. So both the Commonwealth and the state health ministers have agreed to look into the funding models, to look at including the baby in the funding. But we need to keep the pressure up, because now is the time, while they're looking at reviewing funding models and innovations in healthcare, we really need to be keeping the pressure up on both of them. We've had delegations, our members have had delegations to our members of parliament. And in the ANMF federal budget, the pre-budget submission also calls for midwives who remain with their mothers are counted as an additional patient. And again, I don't mean patient from a sickness model, but just within the context of being counted in the hospital. We have had the government election commitment around ratios, which included maternity. So there was prison health, I think mental health, EDs and maternity. We have that has been a long time coming, because the burdensome or the bureaucracy of Queensland Health means things that can take quite a long time, and finding agreements, finding where we're going to do the trials. We had COVID. There was a long time before they decided what funding was going to be attached to it. So it has been rolled out over the last few months at Gold Coast, and preliminary, we're hearing that midwives are pretty happy and that they are finding that they are able to do the care that they want to do. So particularly around newborn checks and those sort of activities, which are really, really important to do with the mother, you know, or the parent, so that you can be educating them and supporting them as well, because we know that some women are going to ringing 13 Health postnatally for some very, very basic information, like, why is my baby's poos changing colour, which we know is normal in that first week, but women don't know. And if they don't, midwives don't have time to support them and educate them and remind them, then these things can become quite stressful for women who don't know any better. So we will see how that goes. It's just the one site that we ended up able to get. So the big picture, we're going to do another audit on May the 5th, which is International Day of the Midwife. It will be the same. We're going to have, that's going to give us a lot more of that evidence around the workloads and the pressures that midwives are under, and it will help us to continue putting pressure on the governments. So the key demands are around the government overhauling the funding models, so newborn babies receive appropriate funding and accounted in midwifery workloads. A commitment by the Queensland government now to ratios. We want our state government to lobby, which they have said they will, the Commonwealth, and work with the Commonwealth to have funding for maternity services incentivises wellbeing and health rather than activity or intervention. And we want both governments to create a midwifery workforce plan into the future, because we know that that's quite problematic, and not just for midwifery, but I know there's lots in the nursing space as well, but I can only speak for midwifery. So private hospitals. We are keeping up the pressure on the private hospitals as well. There's different ways of being able to lobby private hospitals, but our midwives who are working in private hospitals are getting stronger and stronger in their voice and standing up. And we had really good buy-in with our last audit. So we will continue to support those midwives, and we will continue to pressure all health services to have midwifery ratios. And I personally think that if if the Royal Brisbane had women had a midwife that was able to provide that care. So the midwife only had 2 or 3 mothers, 2 or 3 babies to provide care to, then the pressure is going to be on MARTA to do that as well, because those women are going to be saying, well, why does my midwife have 8 women and 8 babies? So for members, for non-members, for the community, for everyone, what can we do? Join our campaign, and I'll let Leash talk to that a bit more soon. For midwives, continue with the workload forms and writing for coding. We all need to talk about the issue that women, babies, persons and families need and deserve quality midwifery care, support and time. To care for in the early days is so important. This is the start of these families' journey into parenthood, and and it's hard enough without having that right support at the very beginning. It's so important. Continue to call on state and federal governments to ensure every baby is funded and counted. Counting the babies on May the 5th. So if you know, for anyone, if you know you're not working, say if you're a midwife but you're not working on the day, you can ring your unit and remind the midwives to do the audit. If you're nurses and you know it's a day, you can check in with your midwives, remind them, remind midwives who are not members that they can do this campaign, the audit as well. So we're reminding your colleagues to fill out the survey. And Kate before was telling me a great one with thinking of any chance to get a time to talk to anyone of influence or not, or just to get it around. There's some key things around counting the babies, that some midwives are caring for over 9 babies in one shift. That's 20 people that midwife's care. Do you realise that? These things are really important to continue to share. And I'll let Leash jump in now.
Yeah, thank you for that, Belinda. Hi, everyone. My name's Leash Dawson, and I'm a campaign coordinator here at the QNMU. So I'm just going to let you know about next steps in terms of us contacting you and what we're asking of you. So I know there are a few QNMU officials and employees here in the webinar today. So in terms of contacting, I'm just speaking to our QNMU members. Okay, so members that attend or register for any of our webinars this week, we have had 2 earlier in the week, Monday and Wednesday, and we will be reaching out to you. So as Belinda has already explained, so the federal government requires more evidence of the issues around workloads in midwifery. So we need to provide them with more data. Okay, we did the first audit and we just need to add to that data. So we're looking at, Friday, the 5th of May, which is International Day of the Midwife. So the same audit will run again if you were involved in the first one. So at the end of each shift, we'll ask you to fill in a Survey Monkey. And for this audit to be successful, we need as many midwifery units as possible participating. So we need information out there. We need all midwives talking about this. The week leading up to the audit, so Friday, 20th of April to Friday, the 5th of May, we need information distributed throughout this midwifery unit. So if you're a member, yes, you will receive information from us, you'll receive text messages and emails, but we need non-members participating in this as well, okay, which is why it's so important that we have contacts out there that can share the QR code and so that they are completing this. So midwives and non-members will, midwives and non-midwives, because we do have nurses attending these webinars, will all receive a text message from us if you've registered for these webinars, okay, over the next coming days. So it's Friday, you receive a message by Tuesday next week, and we will ask you if you're happy to distribute this information, remembering that we cannot do this audit unless we have this information out there. If you respond yes to that, a QNMU official will give you a call to answer any other questions you might have. And for those that registered but didn't actually get to attend the webinar, we can give them another briefing over the phone. And then we'll just need to confirm all your details. So we need to have an address, an up-to-date address to post information out to, and just confirming the site, that the midwifery unit that you're working in as well. Belinda, if you could just jump to the next one. Thank you. So please, midwives, participate in this audit. We are relying on that, and for you to tell your colleagues to participate to participate in it as well. Midwives and non-midwives and members of the community and anyone who cares about babies and mothers and midwives need to join the campaign. Okay, so you can join the campaign by heading to the website. We've already had in the past week 800 new signups to our campaign and through our petition, which is absolutely amazing. So if you can share that, share it on your social media, but really we just need you to spread the message. Okay, back to you, Belinda.
Thank you. I just want to reiterate for everyone, for the midwives to know that on the day of the audit, they will get 3 text messages. And so we're just letting everyone know to expect that, because A, we're not spamming you, but what we knew from the last one is when we put out a text message in the afternoon to remind midwives to do the survey, we had a real spike in people filling out the survey. So we feel that was successful. So we'll be doing 3 during the day at the end of shift times. So that just as a reminder, so don't be stressed if you feel like you're getting a lot of text messages from us. So I'd like to thank everyone for their time, and this is very exciting. This is going to be really good when we get our when we get our babies counted, and when midwives can come to work and feel like they do the work that they want to do, be the midwife they want to be. I think we'll attract midwives back into the profession. I think we'll keep midwives in the profession because we know we've got a lot of midwives with the intention to leave, and not enough midwives coming in. And then midwives can feel that sense of joy in being a midwife, because they can be with women and families and provide the care that they do so well. And what's even more important, of course, is that women, people, and families get the support that they need so that their parenting journey starts off in a really healthy way.